All right, good evening, everyone. Thank you for attending our Mask Together America Expert Forum on the ending of the public health emergencies. My name is Sarah Cahill. I am the coordinator for Mask Together America, as well as your MC tonight. Please have your favorite mask on hand. At the end of the webinar, we're going to take a mask selfie together for the event. We are privileged to have 3 experts joining us tonight who will be able to answer our questions. First, I'd like to introduce Julie Lamb. She's the founder and leader of Mask Together America, which is our grassroots awareness group. Julie is a New York-based writer and artist with an MFA in creative writing from Lesley University. Prior to pursuing writing, Julie worked as a creative director at several Boston and Manhattan advertising agencies, creating memorable and award-winning campaigns. Today, she directs her work to promote community masking through video PSAs, street photography, and story sharing. Julie, thank you for your work and leadership, and the floor is all yours.
Thanks for the introduction, Sarah. As the founder of Mask Together America, I welcome all of you to our first expert forum. We are honored to have 3 heroes who have worked so bravely throughout this pandemic as our speakers here tonight. Dr. Helen Pesola works at the Department of Veterans Affairs in New York. She teaches ICU nurses that treat COVID patients. Dr. Angelique Cothos is a biochemical anthropologist and researcher who studies the virus. She's affiliated with Doctors Without Borders. Dr. Robi Tamargo is a clinical psychologist, a consultant to the Naval Hospital in Florida. With help from these wonderful speakers tonight, we, Mask Together America, ask for your help to urge the government to continue to educate the public about the combined benefits of vaccines, masks, testing, isolation, and treatment. Millions of long COVID patients have been disabled as COVID-19 continues to spread and take lives. Instead of making an effort to reduce the health risk, our president and the Congress decided to lift the pandemic emergency orders, pretending that COVID-19 is under control in the U.S. Post-COVID symptoms such as POTS, ME/CFS, and organ damages put people out of work. We are heading in the wrong direction by stopping promoting COVID mitigation and leaving the doors wide open for the virus. We're still losing thousands of lives every week. Don't let anyone tell you to stop wearing your mask. And please sign our petition that can be found in the chat. I thank everyone for supporting Mask Together America's awareness work.
Thank you, Julie. I just dropped the link in the chat again, just in case anyone didn't get it the first time. And now we're going to move on to our expert forum portion. I'm going to introduce to you first Dr. Helen Pesola. She's a highly accomplished healthcare professional with over 40 years of experience in the field of nursing. She holds a Doctor of Nursing practice degree and a board-certified adult nurse practitioner and critical care certified registered nurse. Throughout her career, Helen has worked in a variety of healthcare specialties, including emergency medicine, interventional radiology, and as a critical care nurse manager for over 20 years. She trained at McGill University, Montreal, in neuroscience. In addition to her clinical work, Helen is also involved in nursing education and research, serving as an adjunct faculty member at several universities and publishing numerous articles in peer-reviewed journals. She's known for her compassionate and patient-centered approach in nursing. She's a respected leader in the nursing profession and has received numerous awards and recognitions for her contributions to the field. During the COVID-19 pandemic, Helen traveled the New York subway every day to work and provided nursing training to new nurses, agency nurses, and non-clinical staff, ready for deployment into the clinical setting in an effort to alleviate staffing shortages. She was awarded the Employee of the Month by the Department of Veterans Affairs, New York Harbor Healthcare System, New York campus, where she currently holds a position in nursing education. She's the national president of the Department of Veterans Affairs, Veteran Educators Integrated Network, with over 1,200 members. Without any further ado, I'm privileged to introduce to you Dr. Helen Pesola.
Thank you so much, Sarah, for that introduction. Good evening, everyone. Thank you to the organizer of Mask Together America for inviting me tonight to share information about the implications to healthcare when COVID-19 emergency declarations end on May 11, 2023. I'd like to go over first the, not yet, I think. I'll let you know for the next slide. So we all know that COVID-19 was declared as a pandemic by the World Health Organization in December of 2019. And the United States has declared COVID-19 pandemic in January of 2020. And we have lost a lot of loved ones because of the pandemic. Next slide. So a lot of people think that the pandemic is over. In fact, the data shows at this time that COVID-19 reported cases, new cases, are down by about 90%, and COVID mortality or deaths are down by about 80%, and hospitalizations by about 80% as well. But we have made significant advances in containing this very contagious disease. However, looking at this graph here, this is being put daily by the Centers for Disease Control and Prevention. So this is a tracker. So looking at the number of cases, this is updated as of March 8th. There's one from yesterday, but I was making my slides, so I made the Wednesday as part of my slide, Wednesday tracker. So on a daily basis, the new cases up to now on a weekly is 226,618. Mortality or deaths is 2,290, and hospitalizations is down to 3,087. And vaccinations, we're talking about vaccinations with booster dose. There was the bivalent dose, which is a new one, but we could do a lot of work in here because it's only 16.2% of the total population, US population. So overall, to date, from inception, the total cases is about 103 million plus, and the total deaths is 1.1 million, around that number. And the current hospitalization is still about 18,000. So these numbers, speak a lot. COVID is still not over, but a lot of people believe that it's over. What's going on here is hospitalizations are down because a lot of people have been vaccinated. But what we see in our ICU are patients who are very sick, high-risk population, who are unvaccinated. And it's really unfortunate that we see deaths day after day, though the volume is less compared to the pandemic. Next slide. Okay, talking about vaccination. This data was taken again from the CDC, and you could see that the population in the United States, only 68% are vaccinated and 34% are boosted. There is no differentiation whether this is a monovalent or the bivalent. But looking at the high-risk population, 65 and older, 93% of them are vaccinated out of that 68% of all ages. And then out of the 34% who are boosted, 67% are 65 and up. Next slide. So if you are vaccinated, this is the science. Looking at the black graph above, those are the unvaccinated people. That's the mortality of unvaccinated people. Vaccinated with an updated bivalent, which is the green one, they have almost 10 times lower risk of dying from COVID-19. The blue are those who are boosted and vaccinated with the old one, the monovalent. So they have about 2.5% of mortality compared to those unvaccinated. But if you have the bivalent, you have a better chance of survival if you get sick of the COVID virus. So it shows that vaccine works. But that doesn't mean that you're immune to the disease. You can. I'm vaccinated. I'm boosted. I still got the virus. But a lot of people who are sick stays at home now because the symptoms are not as severe. There's no shortness of breath of a lot of people. The saturation are not down by 90%. So they are advised to stay at home 5 to 7 days, and they could come back to work without a repeat PCR test. And they do well, unless you have a very high risk and you're immunocompromised and so forth. So again, daily hospitalization and admissions are down. But if you look at the breakdown, 70 and older, there's about 10 patients every day that are admitted, new cases of COVID. 60 to 69 age population is about 3 people are admitted every day. And overall of all ages is about 2. And obviously the younger population, it's 0.7. So if you are 60 and older, you really belong to the higher high risk population. Next. Okay. This information is from the Department of Health and Human Services. This is updated on a daily basis. So I pulled this on March 5th, and it shows that the average new reported cases of COVID is about 33,000. And the average is about 33,000, and the new cases are about 1,500, because some of them are reinfection. So the purely new cases is about 1,500. Next slide. Again, this is just a graph from inception, the total number of cases on the above graph, and the numbers below showing the daily cases is 33,000. Test positivity on PCR is about 8.3%. Hospitalized about 26. ICUs are really down, and deaths are still 538. That's still a lot of lives lost. Next slide. Globally, these numbers are probably not a true representation. This is probably undercounted because some countries might have technology issues in reporting the total hospitalizations and mortality. So overall, globally, the total confirmed cases of COVID is over 758 billion, and deaths are about 6.8 million. Looking at the different mortality rates by world region, so Africa has the highest mortality rate, Oceania or Australia, South America is next, then North America, Europe, and Asia. And that doesn't include China. You can't really get an accurate number from the Chinese mortality data. Okay, so when you're sick with COVID, people have different signs and symptoms. And post-COVID, that's what they call the long haulers. They develop, you're never the same again after COVID. And me speaking for myself, I was tired for at least 3 months after I had COVID. Although I went back to work after 7 days, me, a workaholic, right on the front line. So if you have COVID, these are the reported signs and symptoms that people develop. So they looked at the long haulers on initial survey, that's the blue bar. After 3 months, that's the green bar. After 6 months, that's the purple, darker green. After 9 months, and after 12 months. So they basically looked at the whole year post-COVID. So what they found out, so for cardiovascular symptoms, though compared to the other graphs, bar graphs, it's not as high, but people develop chest pain, people develop palpitations, people develop congestive heart failure. But if you notice, from the 3 month to the 12 months, there's really not a lot of change. It changed a lot from inception, but after the 3rd month to the 12th month, really there's not a lot of change. The next bar group are the constitutional symptoms. What are constitutional symptoms? They are symptoms like you're tired, you have chills, you have fever, you are just feeling hot, and you're just not feeling well. Again, it's a little higher compared to cardiovascular, though it drastically changed after the 3rd month. But as you notice, the trend is after the 3rd month, they sort of remain the same until the 12th month. The next one is gastrointestinal symptoms, and those are the symptoms such as diarrhea, nausea, vomiting, or abdominal pain. Again, looking at the 3rd month, which is the second bar graph, to the orange one at the end, that's a 12 month, it remains almost, it plateaued. Then the next group are the next group are head, eyes, ears, nose, and throat symptoms. A lot of people have this type of symptoms, which is reflective in the data here. But again, the same pattern after the initial survey, it remains about the same. Then the next one is musculoskeletal symptoms like fatigue, aches, joints, and all body aches. And the last one is our pulmonary symptoms. Say, for example, shortness of breath, wheezing, especially people who are COPD, they really have difficulty with their ambulation and shortness of breath. So these are significant post-COVID symptoms that people still have. Okay, so what is the forecast? What is the prediction of mortality in the United States? This data, I took it as of March of 2023. So what they're saying is, just look at here. What they're saying here that they're predicting that the new reported COVID-19 deaths will remain stable or have an uncertain trend over the next 4 years, with about 700 to 4,200 new deaths likely reported. That's scary still. 700 to 2,400 to 4,200 is a lot of lives. Losing one life or a loved one, a friend, or a family, it's a lot for us. So we need to brace up ourselves and still continue to protect, wear masks, social distancing. If you're inside, you know how to protect yourself. It's basically common sense. And people are reckless and they just don't care. And I'm riding in the subway all the time, and in the morning there are less people, so I go to work at about 6:30, so I'm okay. But when I come home at 4 o'clock, there's about 15 or 20% of the riders are wearing masks, and yet people are coughing in the subway. There's no social distancing. It's a scary feeling because you don't know what kind of strain will come. Okay, next slide. Okay, so COVID health emergency timeline. In January of 2020, they declared the public health emergency. Okay, so the public health emergency is renewed every 90 days. This has been renewed multiple times. In March of 2020, the National Emergency Declaration was issued by the president. At that time, it was President Trump. And this is renewed on an annual basis. President Biden renewed this up to 2022. However, he has the power to discontinue this or leave it the way it is, or Congress can also discontinue or leave it the way it is. At this point, these national emergency declarations are still in place, but President Biden is probably going to discontinue this as the public health emergency flexibilities are discontinued. We don't know yet at this point, but my feeling is it will be discontinued. And in January of this year, President Biden extended again the national emergency up to May 11, 2023, and then ended on that date. I work in the federal facility, and we had a town hall meeting this Wednesday, and I asked them how are we impacted with this ending the public health emergency. The response of the CEO was, we have not gotten yet the updated directions or directives from Washington, D.C. So I think they're still weighing things out. And the other emergency declaration that will remain the same, and so far will probably not be discontinued, is the use of Emergency Use Act. So if they have new medications, new treatment, no new vaccine, no new testing, it will probably be approved through the Food and Drug Administration. Okay, so what are these emergency declarations and key flexibilities? As you know, during the pandemic, being an emergency, we sort of lax all of the laws that we have related to healthcare. So what will be affected? Coverage, cost, and payment for COVID-19 testing, treatment, and vaccines. And I'll go over all of those in a few. Medicaid coverage and federal match rates. Telehealth will be affected. Other Medicaid and children's health insurance program flexibilities will also be affected. Other Medicare payment and coverage flexibilities. Other private insurance coverage and access to medical countermeasures. And this include vaccines, tests, treatments through the Food and Drug Emergency Use. Okay. So basically, people are going to say, what are all of these? The one word that I can describe it at this point is confusion. Confusion and the lack of people's knowledge about this information. They're going to say, what? I can't get any more of this. I used to do this. So for coverage, costs, and payment, if you have a private insurance, okay, you are no longer eligible for your 8 free home COVID tests each month. Okay, so that will stop, and you will probably have cost sharing. So I recommend you stock up now from those free COVID tests that are available, or you could go to the pharmacy because it still will be covered by insurance. However, vaccines will still be free for everyone, regardless. So you could still get vaccinated for free. But if you have a private insurance, you might have to have a copay for Paxlovid or to get your PCR test. So that will impact people's finances. If you have Medicare, in terms of vaccine, you're free. In terms of testing, test kits, you might have to have a copay now. And treatments, you might have a copay as well. And PCR tests. If you are a Medicaid recipient, it's about 4.4 million might lost this a free freebie. You will still get access. At this point, you will get free for everything. However, they are saying that this might end 2 months after the end of the following year's when they stop the pandemic. So for example, if they stop the pandemic now, this will end for them in December of 2024, unless they extend it. And the states and the cities can make their own laws however they want to decide to pay for it. And for those who are uninsured, you're well aware that during the pandemic, anybody gets it for free. Whether you're getting the vaccine, you're getting the treatment, you're getting the PCR testing, or you're hospitalized, or you are in the ICU, it was all free. So when this emergency health is discontinued, they are the people that will fall into the cracks because the freebie will end. Telehealth. I think I have it in my next slide. Can you move to the next slide, Sarah, please? Okay. So I have this all lump. So the COVID-19, what are the flexibilities that will not be affected? As I said, the vaccine will not be affected. Paxlovid and this other drug, this new drug for COVID is Lagevrio, will be available, but depending on your insurance. Continued access to emergency authorization use for drugs, that will not be affected for tests, vaccines, and treatment. And telehealth. Partly telehealth will be affected because when COVID came, a lot of providers and hospitals went to remote. So if you have, let's say you have an alcohol problem or you have a drug problem, they can see you remotely without coming to the hospital. And the insurance will pay. But technically now, the first assessment, you need to come on a face-to-face basis in order to get paid. The other waivers that they have is nursing homes. Nursing home patients, they're not paid unless they have a 3-day hospital stay. They are going to take that away at this point. And most of the hospitals, because they were so strained with their resources, staffing, equipments, and all, and they were paying agency people to work. So when they get reimbursement from CMS, their reimbursement is 20% higher. They're given another 20% just to cover the cost. Because a lot of hospitals really was very hard to break even. And they lost a lot. The agency people are not cheap. I will tell you, if you have an agency staff for a year, that's equivalent to 3 people's salary as a regular staff. So, okay. The other changes that will be affected, I think I have discussed some of them. Reporting. Oh, this one. Currently, the CDC requires facilities to report hospitalizations, new cases, mortality, but that will stop, or it will be optional for them to report to the CDC, which means we might not be able to get accurate information. The FDA will have the ability, this will change. The FDA might not be able on a current basis to detect early shortage of critical devices related to COVID-19 because they are not going to be reporting this to the CDC. They're not required to report to the Health and Human Health and Human Services. So they might be able to recognize the shortage, but it might not be a timely basis. The ability of healthcare providers to safely dispense controlled substances via telemedicine will be affected, as I alluded before. And the Public Readiness and Emergency Preparedness Act liability protection will also be impacted. So that's a lot. We have been lax and we have been very fortunate to curtail this disease, but at the expense and services of all of these. So I think the government is looking at this very seriously to stop the public health emergency, but it's not over yet. And I hope we don't have a surge. Okay, as Sarah alluded, I work for the Department of Veterans Affairs, and on Wednesday, they gave us a new guidance. And this came from Washington, D.C. But if you look at the guidance, masks are still required for staff and visitors in any areas where patients are typically present. And that includes inpatient, outpatient, the lobbies, the elevators, the corridors, cafeterias, gift shops, and common areas. Masks might be lax or optional in non-clinical areas, like, for example, engineering, HR, where there are no patients in there. But in general, I don't feel the change, because I can walk to a clinical setting and go to engineering if their department is close by, and you have to wear here, not to wear here. So a lot of people feel, because I ask a lot of people, are you comfortable removing your mask? And they go, heck no, we're in the hospital, we're gonna wear this. And so it was very comforting to know that people still believe that wearing masks is important. And a lot of hospitals have changed their policies. I know for a fact that NYU have changed. It's optional, but in the clinical area, the patients are still required, and the clinician. Mount Sinai continues to have their mask mandate, while Cornell Medical Center and Columbia Medical Center, they're still wearing their masks, as well as the city hospitals in New York. So, okay, so given that information, the pandemic isn't over, and it's not going to be over for any of us until it's over for all of us. We are only going to get through this pandemic with a collective approach, according to Dr. Thill, who is a CDC physician and a New Yorker. And so let's continue what we're doing. Let's continue to wear masks, and let's save lives together. Thank you.
Thank you so much, Dr. Helen. We appreciate your expertise. Our next speaker is Dr. Robi Tamargo. She is a doctor of psychology in clinical psychology cum laude. She's a Truman Scholar and a decorated veteran. Dr. Tamargo completed her clinical internship and residency through the Bureau of Medicine and Surgery at the National Naval Medical Center in Bethesda, Maryland, serving 5 years on active duty as a naval psychologist and earning the rank of LCDR. Leaving active duty to start her private practice in Manhattan Beach, California, she relocated to the East Coast in 2001. In 2013, Dr. Tamargo expanded her practice to Ponte Vedra Beach, Florida, providing psychotherapy and assessments for children, adolescents, adults, couples, and families. She specializes in trauma and is a consultant to the Naval Hospital in Jacksonville. Dr. Tamargo is also a long COVID survivor. To seek post-COVID care in New York City and participate in long COVID clinical studies, Dr. Tamargo and her husband left Florida on October 28, 2020, after her 5th hospitalization found her still deteriorating. Following a weary journey with numerous hospitalizations, medical procedures, and being scrutinized by innumerable tests, Dr. Tamargo continues to battle chronic COVID symptoms, including neurological, cardiovascular, respiratory, musculoskeletal, gastrointestinal, autonomic, dermatologic, and mucous membrane. After a year of high-dose steroid treatments, she's severely immunocompromised. Dr. Tamargo has been featured on NBC to speak about the mental health impacts of long COVID, and we are privileged to have her expertise on the team at Mask Together America and with us here tonight. So without further ado, Dr. Robi Tamargo.
Thank you, Sarah. What a lovely introduction. Thank you, Julie and Liam at Mask Together America, for inviting me to participate, and I'm very honored to share the stage with Dr. Pesola and Dr. Angelique. So tonight I want to talk about my area of expertise, which is mental health. I'm a clinical psychologist, and I just also happen to be a COVID long hauler. So I wanted to share what I've learned and continue to see as a psychologist as I've been able to recently return to practice. So here is a slide that provides the typical clinical presentation in long COVID. And I just wanted to highlight for everyone that essentially every single organ system in the human body has been affected to some degree or another for people with long COVID. Some people only have one organ system involved, and others have many, and some even have all of them. So it's a very interesting disease process because while the symptoms are similar, not everyone experiences all of the same symptoms. So it's a really heterogeneous community. Thank you. Next slide. So I wanted to point out that long COVID is not just general symptoms. This is an extreme illness in which people feel a level of exhaustion that they'd never felt before in their lives. I'm a runner. I've been a competitive racer since I was 12 years old. And I also played 2 sports in college, field hockey and lacrosse. And I have never felt the level of fatigue and exhaustion that interferes with your daily life. One of the things that's really interesting about long COVID is that our symptoms get worse after physical exertion or mental exertion. And this is referred to as post-exertional malaise. And a lot of people don't understand how they can just work on a college paper and then not be able to get out of bed for 3 days, or just go for a very little walk. And the same thing, they may not be able to get out of bed for days at a time. Of course, everybody's heard about the fever and the respiratory and the heart symptoms. And I, of course, experienced all of those. And I continue to this day. I'm about to hit my 3-month COVID 3-year COVID anniversary on May 7th. And I still have difficulty breathing and shortness of breath. So you may notice that as I go along, I will have more and more difficulty breathing because, believe it or not, doing a presentation is malaise waiting to happen. I coughed for probably 2 solid years, and I still have random chest pain just because. I was diagnosed with atrial fibrillation 3 months into my post-COVID battle. And I had never had any cardiac issues in my entire life. And I was, before I became sick on May 7th, I was one of those folks who got up at 5 in the morning and went to the gym and worked out every day. And so to not be able to walk up steps, or there was a very lengthy period where I wasn't able to walk at all due to neurological symptoms, which is the next thing on the list. Difficulty thinking and concentrating it has a colloquial name called brain fog, and a lovely name, but it is completely an inaccurate thing. And it's a really significant neuropsychological injury to long haulers' brains. And we need to understand that there is nothing cute about what happens to people neurologically. I had a headache for 18 months daily, the worst headache of my entire life every day. And it took quite a while to figure out how to get me some relief. And it was really a challenge. I developed the sleep problems immediately with long COVID, immediately with COVID, which a lot of people do. I, of course, was so sick, I couldn't breathe. I was coughing, all of those things. And I had to sleep propped up so that I could try to breathe. And it got to a point where my body just wouldn't sleep, and I would be awake for extremely long periods of time. And it was many, many months of me talking with my neurologist about, gosh, when am I going to have hallucinations? I haven't slept in so long. And I ultimately did enjoy the pleasure of hallucinations. So it really is a very devastating disease. A lot of us are experiencing dizziness or lightheadedness when we stand up and when we bend over. And a lot of that, often that's referred to as postural orthostatic tachycardia syndrome. And it's a very bizarre feeling, and nobody wants to wish that on anyone for sure. I will periodically have the pins and needle feelings, bizarre random places in my body. And from the first day when I got sick with COVID, I never lost my taste or smell, but I had the change in smell and taste. And those are neurological symptoms. And the change was that I smelled smoke. And I thought for sure there was a fire. It was May, so it's like, why would there be a fire? So I came out and I'm looking for the source of fire, and everyone in my family's looking at me like I'm crazy. And so that's persisted. Things taste bizarrely to me. They smell. I can't drink water out of our tap. It just tastes disgusting. My favorite bottled water tastes disgusting. So there are a lot of interesting symptoms that people don't necessarily connect with long COVID. The diarrhea, the digestive system issues, well, that's profound. And for my husband, that's his only symptom that he had when he had COVID, was he had 4 days of diarrhea, and that was it. And of course, I had 99 consecutive days of diarrhea, and those are really good times. And I just continue to have digestive issues, as many people do. Stomach pains that you're pretty sure that your stomach is rupturing, joint muscle pains. Every joint in your body hurts, every muscle hurts. I've had probably 25 rashes, very bizarre things. I've had strange disease processes with my fingernails and my toenails. I've lost my hair. So all this really fun hair that's just strange lengths, and it's very fuzzy these days. Lots of women have really significant changes in their menstrual cycle, extremely severe pain when they're getting ready to have their cycle, and heavy bleeding, and a whole host of other symptoms. There are studies that have over 200 symptoms that have been identified in a very large cohort of long haulers. Thank you. So this slide is a wonderful study that was published in the British Medical Journal. And this is a slide that was purposely made to teach primary care providers about long COVID. I did a presentation at the clinic where I work as a consultant, and I presented this material to the primary care providers. And they were also incredibly appreciative to have much more specific data to help them. And I see a lot of patients that tell me that their primary care providers out in town don't have any idea how to treat them. And I just met a woman this week who has very clearly has long COVID. She's had all these abdominal pains and the menstrual cycle issues, and she was complaining of this severe pain. She saw every specialist that she could be referred to, and finally they said, well, we can't find anything wrong. It's in your head. You got to go see the shrink. So she came to me, and now she was telling me her story. It was just very obvious. So I did a long COVID symptom check with her, and she had almost every single symptom that had just not been identified. So, goodness gracious, it was just identified that abdominal pain, it was a blood clot in her gut. So here she is, several months out from her instance with COVID. and almost a year, in fact, from when she became ill. Her COVID anniversary is the same as mine, just 2 years different. So I put this here so that people would know about this article, and I encourage everyone to print off this article and take it with you to every appointment you go to, so that your physicians can look at it, because providers are incredibly busy, and they often don't get any time to take a break to go to have lunch. They're seeing lots and lots of patients. They care very deeply about their patients, and they often don't have time to keep up with the literature. And I think that's just a reality of where things are right now, with a shortage of providers, and particularly in this area, this region of the United States. We're extremely short of providers in pretty much every specialty area. So I hope people will find this particular slide very interesting, and provide it along with the article to your family care providers. So let's talk about some more impact of COVID-19. So I wasn't able to work for 2.5 years. I didn't know how to work a telephone. I couldn't use a calculator. I couldn't watch television or listen to music. I couldn't stand a fan on in the room. So I literally was forced, because I became neutropenic because of long COVID, that I was in social isolation for an extremely long period of time. And fortunately, I was able to handle that and not become depressed. And I'm going to talk about depression later. And I'll share my experience with the hallucinations a little more deeply, as well as other mental health struggles that I have experienced myself. I share this very personal information because I want everyone to understand that it doesn't matter who you are, what kind of job you have, no one is immune from this disease, and any one of us who gets COVID tomorrow can still become a COVID long hauler. And that data has not been well publicized around the world. And millions of people have died, but millions of people have become COVID long haulers as well. And that's something we need to understand. So long COVID affects everyone, regardless of our race, our age, or gender, or our baseline health status. I was in really incredible physical condition when I became ill. And I'm certain that if I hadn't been in the condition I was in, I would have probably died, because I've been hospitalized close to 30 times now. And in my most recent hospitalization, I had an implant put into my heart. And before that, I spent 40 days and 40 nights in the hospital. So, and that was just last year, from January until February. I became ill on Christmas Day. And so that's not a really good time to be really ill, I can tell you that. There's a new CDC study that reports that at least 30 days after having long COVID, 1 in 5 COVID-19 survivors aged 18 to 64, and 1 in 4 survivors aged 65 or older have a long-term health condition that, in their languages, might be related to their previous COVID-19 illness. I'm sure if there are other long haulers on this call, you're all screaming, might be, is so clearly related. And more things are being published, but that's the challenge, is that studies are behind. So things are getting published now from over a year ago. And so there's a really big delay. And until things are published, then it's considered anecdotal. And so there are many anecdotal long haulers that can tell you exactly what people are experiencing. So people who have had previous COVID illness had twice the risk of developing pulmonary embolism or respiratory conditions. So the more episodes of COVID you get, the greater your risk becomes. So I want to let people know that, because the pandemic isn't over. Whether or not we terminate the public health emergency, that's a political decision, but the pandemic is not going to discriminate. And I became ill in the first round before there was any vaccination available. And I got it from one of my patients who was an active duty physician. And we had spent an hour in my treatment room together wearing material masks, because there were no masks to be had. You had to make your own at that time. And obviously didn't work for either one of us. So I want people to really understand this particular study looked at 26 different conditions that are known to occur after COVID-19 and referred to as the post-acute sequelae of SARS-CoV-2. And the report found that people that had past COVID-19 had twice the risk of developing a new condition compared with people who without evidence of COVID-19. So the fact that people got sick, developed all kinds of new symptoms. I had nothing wrong with me before I became sick. And now I have just this ridiculous number of organs that are damaged. The highest risk, of course, are the lungs. And because we're all aware of the respiratory symptoms that are killing a lot of people, and we're still losing over 1,000 people a day, as was reported earlier. And I think that's way too many people that are still losing their lives. And we need to take steps. And as some of you may know, I am a founding expert of Mask Together America. So I'm always advocating for people to wear their masks. And mine is right here. I go nowhere without it because I've become neutropenic. And so lots of things are dangerous to me that aren't necessarily dangerous to other people, and were never dangerous to me before. The other issue is this vascular disease process that is often referred to as microclots. And I think it's important for people to understand that a lot of pain that they're experiencing in their muscles and their joints are actually microclots, and they're too small to be seen on an ultrasound for a blood clot, and they don't show up on a D-dimer test. Not only do microclots not show up, neither do other large clots, because I had a negative D-dimer test when I went to the emergency room last January, and a year ago January, not the one just a couple months ago. And I had a very severe blood clot, but the tests that they gave were all negative. But eventually, because I was literally screaming in the emergency room in such excruciating pain, that they took me in and did an ultrasound. And I can tell you exactly where this blood clot is. And that, yes, it was exactly there. And for the docs in the room, it was in my perineal, my left perineal vessel, right under my ankle bone. And it was horrifyingly painful. So in addition to that, I developed very recently, after I had developed a blood clot while on one blood thinner, Eliquis. Then I was put on another blood thinner, Xarelto, and I got another blood clot, this time in my popliteal vein. And then this past May, I developed another blood clot, and I was on Plavix and Xarelto. And I still developed a blood clot. And you hear people talking about this bizarre disease process where you continue to develop clots despite being anticoagulated. This is why I had the surgery on Halloween, because I had a genetic patent foraminobali, which is the little hole in your heart that doesn't close in 25% of the population. Never gave me any problem, didn't even know it was there, no issues whatsoever. But because COVID causes so much injury to your vascular system, it stretched that larger, making it me a tremendous risk for one of these blood clots to break free and end up in my lungs or in my brain. So we had a very cool device implanted into my heart to protect me. So we know that there are lots of conditions that affect multiple body systems. The most common new conditions were the respiratory symptoms and the musculoskeletal pain in this study. The CDC study may not be generalizable to a broader US population, but the breadth of symptoms and conditions that are definitely manifestations of long COVID and the scale of this are consistent throughout the scientific literature around the world, except for China, because we don't have any information. So more precise estimates of risk are not available. It is certainly evident that long COVID already impacts a substantial number of people, and this number is expected to continue to grow. Although vaccinations and preventative measures such as wearing a mask and social distancing and being outside definitely are helpful. So what is mental health? Well, mental health includes emotional, psychological, and our social well-being. So our mental well-being affects how we think, feel, cope, relate, and behave. It's how we make choices, how we relate with one another. And so mental health is absolutely more than just the absence of a mental illness. It's really vital to our overall physical health and our quality of life. You can have mental health symptoms and not have a mental health illness. You may not have a disorder. And it's important that people understand that you may have a lot of different mental health concerns post-COVID and be a little bit reluctant to even ask for help because there's been so much psychologizing of COVID long haulers. So I want to stand on the mountain here and say, don't be afraid to speak up. And you can always just ping me, drrobitamargo.com, and I will come to your support and educate whoever wants to gaslight you about telling you that your illness isn't real, because they need to come and participate in my primary care provider training. So what we need to understand is that self-care plays a huge role in maintaining and regaining our mental health. And we have to get lots of support. It's essential that we support our treatment and our recovery by taking care of ourselves properly. So we need proper nutrition. We need proper, for long haulers, our proper exercise maybe is 5 minutes of very quiet walking or some stretching. Okay, so I have some really fun dreams, imagining myself running, playing lacrosse, boogie boarding, kayaking, paddle boarding, playing beach volleyball. Wonderful, wonderful dreams. But I don't know if I'll ever be able to do those things again because of the damage to my heart and lungs. So, excuse me. I think it's really important that people understand that their nutrition plays a huge part. And we've seen that with COVID long haulers, to be very careful about what we're eating, because we can activate our body's system of inflammation. And that just makes everything worse with COVID. So we need to not eat inflammatory foods. And those are things that have sugar in them, or the refined carbohydrates. So we need to stick with whole foods. And there's a huge connection to what we eat and our mood. And it's important that people understand that. So we need to be eating a breakfast, a very healthy breakfast with protein and produce. and a lovely snack that maybe would include some kind of protein, maybe some nuts or some seeds, followed by some fruit. And then a nice lunch that is protein and produce, and then another afternoon snack that is a nice protein. It could just be a hard-boiled egg and some fruit. The best fruits for our mental health are berries because of the low glycemic index. They protect us very well. So to me, mental health isn't just one specialty. It requires a collaboration between psychologists, social workers, licensed professional counselors, all the myriad of names that around the United States we have for counselors of lots of different areas, psychiatry, neurology, and every single organ system specialist. We must all work together to treat this profound impact that COVID has on humans. So how can it impact our mental health? If somebody gets COVID-19, they can experience a number of systems related to their brain and mental health immediately. And data suggests that people are much more likely to develop mental illness or disorders in several months following the infection. Cognitive deficits, which, as I mentioned earlier, it's often referred to as brain fog. Really what it is that our frontal lobe, our prefrontal cortex, isn't working properly. The part of our brain that manages judgment and impulse control and planning and time management, it's not working very well. Our ability to pay attention and concentrate, it's not working. Our ability to sleep, it stops working. And people have profound insomnia. They have trouble falling asleep. They have trouble staying asleep. And then they wake up in the middle of the night and they're raring to go. They maybe slept an hour or 2 hours, and then they're awake for the rest of the day. And then eventually that will switch, and long haulers become profoundly fatigued. They can't stay awake. It's too dangerous for them to drive a car because they'll just fall asleep. If they sit down, this has happened to me. It was the most glorious time as a psychologist. I was working with one of my long-term patients who knows me incredibly well. And I was just trying to come back, and I was only seeing one patient a day. And this was in December of 2022. And we were having our session, and at some point I had a neurologic event, and I was saying all kinds of bizarre things, none of which I remember any of. But I realized that I lost time. And my patient said to me, "Dr. Robi, you need to get up and go to bed." And apparently I got up and went to bed. And I have no recollection of what happened in that session. But my note that I had, my handwritten note was nice in the beginning, and then it was completely illegible. It made absolutely no sense whatsoever. And if I ever publish a book, I'll put that note in there so that people can see. And it just happened like that. And then from that day, then I could not stay awake. And it's almost as if people know what narcolepsy is, where you just cannot stay awake. That happened, and I would sleep all day. My husband would wake me up to give me some food, and then I would go back to sleep. And so it was very, very bizarre experience. So I've talked about some of the cognitive deficits. One of the big ones is people's memory. I have huge gaps in memory. I've absolutely lost essentially 2 years of my life where I have no memory whatsoever. And then there are spots of where I was doing a little bit better, and I have some memories about that. And then there are complete periods of time where there's no memory whatsoever. And I know that's a really common problem that long haulers are experiencing. And so again, the only way you can protect yourself from becoming a long hauler is to not get COVID. So anxiety. So I've never had any mental health issues before in my life. And I always felt pretty fortunate about that, because the prevalence, lifetime prevalence of mental illnesses is actually pretty high. So when we came back from New York to Florida, I was in the car with my husband going to a medical appointment. So keep in mind, when you're in New York City, you're not really going anywhere in cars, right? You have to go on the subway and maybe an Uber once in a while. But I basically went from my apartment to Mount Sinai Hospital many times a week. And so I had no idea what I was about to experience. We pulled out of our community and we're going literally out of the community. And I'm screaming and grabbing the dashboard that these cars are going to hit us. And they're just all the cars who are coming at me. And so my proprioception of where I was in the world was not right. So I had no idea where cars were in terms of how close they were to us. And my darling husband just reached over and touched me, and he said, "We're safe, sweetheart. Those cars aren't anywhere near us." And we had to go on to the doctor. And I kept doing this throughout. I was so terrified in the car. And that has fortunately resolved. And I did for myself exactly what needs to be done, which is expose myself to the very feared thing and continue to see. But for a very, very long time, I can drive now. And I only been driving since November. And so it's a really, really big thing. And I don't go very far, but I don't feel like things are going to crash into me anymore. So that's a big thing. So that anxiety was really, really profound. And the other day, this was just recently, we were going in the car and I went, so I had that moment again where my husband was driving, and I had that moment again, and I was able to tell myself exactly what I teach my patients. This feels very uncomfortable, but it's not dangerous. And so if you're having any of these kinds of symptoms, keep reminding yourself, face the fear, expose yourself to what you're afraid of in increments, little bits. So we started just literally pulling out of my driveway and pulling back into the driveway. And then I would pull out of the driveway and I would go down to the block, not very far, about 50 yards, and then come back. And then I just kept practicing with my husband in the car, driving around the community. And then I made the big trek out of the neighborhood and just kept making little steps, and to like drive. I wasn't going in anywhere because I was still neutropenic, but we would just go in the car and help me to overcome this profound fear. Okay, psychosis. I mentioned that a little bit earlier. I experienced an episode. This was before I went to New York, and this resulted in my 5th hospitalization. And I was awake. It was the middle of the night. And so this was in October of 2020. And I had a goose and a duck in my bedroom. They were just standing next to my bed. Little backstory. One of my things that I have done to help myself is I have been feeding the ducks and the geese in the community. And I've fed many goslings and ducklings, and been brought by their mommies and daddies, these little creatures to connect with. And it was I couldn't connect with humans. It was the only connection that I was able to have. And so kind of makes sense that the ducklings and the duck and the goose were in my room. And so I got up and I said, "Oh my goodness, you guys, what are you doing in here? The food is outside. Come on, let's go." And I started taking them over. And then the goose jumped up on my bed, and I was trying to, get out of bed. And so I'm scooching away to try to get over and say, "Okay, come on, duckling, come on, goose." And then I go to the doorway, and I turn on the light, and I see the door is closed. I'm like, goodness gracious, they got shut in here. No idea what's any sense of reality yet. And then I opened the door. I'd already turned on the light, and I turned around to talk to them, and they weren't there. And right then I had the awareness that I had just had a hallucination. Okay. So I've had colleagues that have told me their hallucination experiences. I've had one colleague had a really serious episode of paranoia, that her neighbors were pumping COVID into her apartment. And so these are the kinds of things that long haulers are living with at home and are scared to death to tell anyone. Okay. So if somebody's telling you something weird's happening to them, they've never had this happen before, and they're not young, the most common ages that will have a mental health break, like a psychotic episode, is between the ages of 14 and 24. You have an older person having psychosis, that is often very typically due to a medical condition. Okay. The other thing that people don't understand about our mental health is sleep apnea. Because of the hypoxia that we endured, I became severely severe, my diagnosis of sleep apnea, and I now have to use a BiPAP at a very, very high dose. It's crazy. So if you're still having episodes where you're waking up in the night and you have to go to the bathroom, you've probably got an adrenaline rush in your sleep, and that's awakened you with a very strong startle response so that you breathe. And so it's important, if you're having any weird sleep stuff, you're waking multiple times in the night, you awaken, you can't go back to sleep, that you ask to see a sleep specialist. Okay, I already talked about the exhaustion. Seizures is another experience that many long haulers are going through. And so if you're having seizures, please see a neurologist about that. Suicidal thoughts, suicidal ideation, fantasies, urge, and actions, sometimes cutting to see if you're alive. People will do that, or they'll burn themselves, or they'll pull out all their eyelashes. And people have never did any of these crazy things before. So understand that these are crazy things, and that's what's the injury that happened to your brain. Okay. And the last thing I'd like to mention is what I was diagnosed with last January, is Guillain-Barré syndrome. And so I on Christmas Day, of course, we had a big morning, right? Santa came to the house and we all had to open gifts. And then I fell asleep in the afternoon, and apparently I slept for 4 hours, and I awakened at 6:30, screaming in this outrageous pain, and I was unable to walk. And so my family was all just waiting for me to wake up before we started Christmas dinner. And everybody was traumatized by these blood-curdling screams that they got to hear for the next few hours. And it's Christmas Day, so guess who's not going to the hospital? And so when I talked to my neurologist who was skiing in Utah, and my primary care provider who was in Colorado, and they said, stay home until you can't breathe. And so that's what I did. And so eventually what happens is the paralysis starts moving up your body. And so eventually I did have to be put on the BiPAP in the hospital. So I lost my ability to walk. It started impacting my ability to breathe. I couldn't use my hands or my arms. I couldn't use my tongue. I couldn't swallow. It was a pretty unbelievable situation. So because it's persisted, I have now what they call chronic inflammatory demyelinating neuropathy. My foot dropped, my left foot dropped. And so I have permanent nerve injury. And so I think people need to understand that this can happen to anyone, regardless of how wonderful your physical condition was. Okay, so the neuropsychological and mental health impact I think I've made the ominous impact pretty clear. Adults and children are being stricken by long COVID. A 2020 study revealed that half of Americans surveyed reported recent symptoms of anxiety or depressive disorder, and 10% of those respondents felt that their mental health needs were not being met. We have around the entire United States a shortage of mental health providers. We simply cannot meet the needs because why? So many mental health providers were stricken by long COVID because we are first responders in the beginning. So the rates of anxiety, depression, and substance use disorder have increased since the beginning of the pandemic. Those who already had a mental illness and then got COVID are much more likely, or have one and then get COVID, are more likely to worsen than those who have never had a mental illness or disorder. And I've already told you how brutal it is for someone, even though you've never had it before. So mental health is a very important focus of research by the NIH and researchers at NIH, and they have provided money, grants for a lot of research trying to study and understand the diagnoses of long COVID, its impact on our mental health, and then improve the treatment. And there's some pretty amazing studies that are in preprint that are just going to blow things out of the water. Because I have been a long hauler for so long, I've participated in, gosh, I honestly don't even know how many studies I've participated in now. And Dr. Akiko Awasaki from Yale collaborated with Mount Sinai to do a whole bunch of studies, and her work is just absolutely incredible. So I'd like to draw your attention to her work. Thank you.
Hey, Dr. Robi, I just wanted to give you just a time check. We still have one more expert to get to tonight. So is there anything that we want to say to?
Just go to the next slide and I'll see if there's anything that needs to be said. This is just about the cases, and I won't repeat what was already said about that, but it really has impacted mental health tremendously. So this is just some data, so we can move through that. I can answer those questions later. Younger people are more likely to report mental health symptoms, interestingly enough. Okay. And we talked about anxiety and depression already. And the substance use is a huge issue. That 13% of Americans started or increased substance use in order to cope with COVID-19. And there are lots of emotional reactions here, and the drug overdose deaths are profound. And people, I already mentioned, are not affected identically, and that should be clear. And this is just a really destructive disease. Okay, We want to protect our kids because developmental brains are really getting crushed. Okay, self-care, got to do it. And these are some tips, and this is a wonderful slide that's available by the National Institutes of Mental Health. Slide after it talks about what is anxiety and depression. Okay. And don't wait till you're overwhelmed. There are lots of services available. One of my favorites is the crisis text line. You can just text 741-741 from your phone, and you'll get free 24 hours a day, 7 days a week texting for young people. If you want to talk to somebody, you can call 988. It's a suicide or crisis lifeline. And there are lots of wonderful resources available to, so you don't have to be at home alone battling this. Okay, seek professional help whenever you think you need it. Don't wait for something terrible to happen. You already talked about the people losing their lives. Every soul is irreplaceable. Families are grieving. It's profound loss to the families and the communities. And the grief is a huge, huge issue. Okay. Beyond health complications, there are other complications. Obviously, the ability to earn an income. There's a labor shortage, and there's this issue of the risk of inflation. All of that has an impact on our mental health. How do we prevent long COVID? Wear a mask, preferably an N95 if you're an adult, or a KN95 if you're a child. Okay. Social distance, use HEPA filters. Here's how you choose a mask. It's right on the CDC's website. This is me. Real life impact just last year. And that's me now. Thank you.
Thank you, Dr. Robi. I apologize for
No, it's okay. I have no sense of time, so this is one of the problems of being a long hauler. No sense of time.
No, we appreciate it so much, and I was amazed. You have 4 slides of references here. You obviously
lots of references.
Have a lot of knowledge on the subject, so we are very, very grateful to have you as one of the expert advisors for Mask Together America, and we appreciate you being here tonight. So thank you. Our third expert is Dr. Angelique Korthals. She's a biomedical researcher and a forensic anthropologist. Her biomedical research is specialized in the link between neurodegeneration, metabolism, and environmental triggers in neurological and infectious diseases, as well as aging. Dr. Korthals' biological and forensic anthropology research focuses on the histopathology of trauma and diseases. These 2 foci of research, as well as her experience building and developing biobanks for both medicine and natural history applications, have led her to be a consultant expert for Doctors Without Borders on diagnostic technology and clinical guidelines for HIV and TB, neglected or emerging diseases for use in low and middle income countries or communities. In 2020, Dr. Korthals received 2 grants from the National Science Foundation in collaboration with her spouse, Dr. Liliana Davalos, an evolutionary biologist at Stony Brook University, to study the mechanisms of infection evasion of coronaviruses by chiropterans, which is bats. I'm sorry if I said that wrong, Dr. Korthals. The first grant is centered on bat goblet cells as immunohotspots for infection of coronavirus, and the second, in collaboration with Texas Tech University, on immunological adaptations in bats to moderate the effect of coronavirus infection. Dr. Korthals is an expert advisor at Mask Together America, and we are grateful to have her with us tonight. So I present to you now, Dr. Korthals.
Hello, thank you, everybody. I didn't prepare a presentation because I thought that what I was going to talk about was going to be why we are out of step now with the WHO. And I see that Jenny from Texas actually really was asking about that particular problem. And so I'm going to start with at the beginning with the end of the public health emergency. And Dr. Pesola and Dr. Tamargo spoke very eloquently about it on two different topics. I'm more nuts and bolts. And one of the things that we keep hearing, not just the fact that the pandemic is over, but also we keep hearing, oh, we now have all the tools that we need. Well, that's not true. We don't have all the tools. What we have is emergency tools that have been really amazing at keeping us mostly alive until now, and in a different way from the beginning of the pandemic. But those tools are emergency tools. They're not perfect. And we still need to develop better tools. We need to have better vaccines. The vaccines that we have right now are great at preventing severe disease, for sure, but they are not preventing transmission. So they're not what we call sterilizing vaccines. We need better research on that. We also need to adjust the vaccine with every other emergent strain of SARS-CoV-2. That's a problem. We really need a pan-coronavirus vaccine. That needs to happen too. We need better treatment than Paxlovid and definitely molnupiravir, which has been found to not be as effective as Paxlovid. And with Paxlovid, we'd like to also avoid that famous recurrence that happens. Another thing that's problematic in terms of we don't have all the tools, we certainly don't have, and that's my pet peeve, of course, I work on diagnostic technology with Doctors Without Borders, is we don't have great tests that are available at home for COVID anymore, because the strains are getting so different that the antigens are not, like the rats test that we've been using, the antigen test that we've been using are no longer working really well. And as if you've had COVID, especially with the latest Omicron variant, you know that your rats have not really shown you being positive until later down the line, like 2 or 3 days after being infected. So therefore, you were out in the world possibly with already an infection ongoing. We know that some other treatment, yes, Jenny, Evusheld, for example, is the really last line of defense for people who are severely immunocompromised, especially transplant patients, is no longer effective for Omicron, especially not the KBB variant, which is problematic. And we also have to still share with the rest of the world. While we are good and fine in the global north, we have these emergency tools available. They're still not available to about 3/4 of the world. So that's a problem. So those reasons in and of themselves should be reason enough for a country like the United States, which is supposed to be a leader in pharmaceutical, a leader in public health, to not stop the public health emergency. Why? Because by stopping the public health emergency, you are stopping or slowing down tremendously the funds that are necessary to actually work on these problems. And we're not doing that anymore. So I think it was on Wednesday, we just learned about the budget of the White House, which no longer going to include that specific COVID funding or COVID emergency funding anymore. It's going to be rolled into the entire healthcare funding, which means that we're not going to have extra fund for basic research, number one, for applied research, for vaccines, for treatment, for better diagnostics. And that's just one of the many reasons why the WHO is actually really mad at the US for ending their emergency faster than they are. And sure, the WHO has said that we are at an inflection point, and I think that Dr. Pesola mentioned it. So the transition point or inflection point is the word that they used in their meeting, has been really a problem, and it's disparity between the WHO and US is really creating a tremendous friction between the agency and the public health services of the US. And part of the reason is that I don't know if you know much about the World Emergency Declaration, the World Health Organization Emergency Declaration. They don't take those very lightly. We haven't had a lot of those. We've had, in 2005, we've had the first SARS. 2009, we had the swine flu. 2014, we had the polio and Ebola, Ebola and Zika, 2014, 2016. 2019, return of Ebola. And then in 2020, that was COVID, and 2022, the monkeypox. And that's it. Those are the emergency declarations that the WHO has done. And what they do is they mobilize the international response. So if you have countries falling off left, right, and center in terms of public health emergencies on their own, especially a country like the United States, which is the biggest country for the public health emergency, these international treaties that the WHO has with other countries are in danger. The WHO does this by implementing a non-binding agreement, but they are sort of practical and politically significant because they allow the international scene and the WHO to address or to put in place measures that are necessary. For example, if there's another surge, right? If there's a new variant that appear and that becomes more problematic or more pathogenic than what we have right now, we would need that to be in place to be able to respond faster. And of course, if the US is out of step with the rest of the world, it becomes really problematic because a lot of the troubles, for example, go through the US. We also count on the WHO and on the public health emergency to curb the spread. And one of the thing that has been frustrating me, and I'm sure all of you, is that we keep playing catch up with every single variant when there is an easy way to stop a variant from growing into the community. And that easy way is the layered approach. You vaccinate, you wear a mask, you get clean air indoors, you isolate the sick, and that those are supposedly simple steps, but they cannot be coordinated without a public health emergency. Why? Because you need fund. You need fund to isolate the sick. You cannot just isolate people and expect that, you know, they're not compensated for their sick leave. So you need the federal government to be able to organize funds to provide sick leave. To do that, unless you go through Congress, which will take an enormous amount of time and possibly be blocked by one group, we all know which, we know that this is not going to happen, and these people are going to be left hanging. With the clean air, that's another thing, is that clean air could happen. And I'm really always perplexed by people just being against clean air. It's like being against clean water. It's like, who would like to go back to the 19th century London cholera water? raise your hand, right? And it's exactly where we are with clean air, right? So again, the federal government could provide relief funds through the public health emergency, to actually retrofit a lot of the facilities out there, or provide small grants to retrofit buildings which do not have the possibility to have ventilation through windows, for example, to have better air inside their facilities, so, like HEPA filters and UV cleaned air, etc., etc. Deploy all of those Corthes Rosenthal boxes everywhere, right? So this is really where it comes down to the nuts and bolts, and it is something that personally, so I have never had COVID in 3 years. So I'm one of the only ones in my entire faculty at work who's not had COVID. And I will ask you, why do you think my secret is? Even though I have been traveling, I have been with patients, I've been working, exactly. I got N95s, right? So I've been wearing my N95 from the very beginning. I was lucky enough that having used N95 before, I had N95 when the COVID pandemic struck. So I was one of the lucky ones to have those, but I've maintained my negative status even with the extremely much more contagious variants such as Omicron throughout. And I've just come back from a 16-hour plane trip to Egypt, of all places, and maintain that status of being COVID-free, despite the fact that nobody was masking on the plane, and half of the plane was obviously very sick. They coughed, they sneezed, their kids coughed, their kids sneezed. It was terrible, right? So the end of the public health emergency has some very serious consequences that are very practical. They're not just the funding to Medicare, the funding for free vaccines and free treatments, which is to a certain extent going to end for some people. It's not just the confusion that it's going to create. My idea would be to roll out the public health emergencies little by little, rather than just say from one day to the other, it's gone and nobody knows what's going on, right? And also maybe wait until the pandemic is over before you roll out a public health emergency. Just saying. So these are the things that I wanted to point out, that this discrepancy, this sort of fracture line between the international community and the US is only going to increase the fracture line that we have here in the US between the federal government and healthcare in general, which we know is really not good, right? So with that, I'm not going to go further because we need to address the questions, and I really want to hear your questions rather than go on.
Thank you, Dr. Korthos. We've been getting a bunch of questions in the chat. It seems like you and Dr. Tamargo have been taking care of some of those, but I want to prioritize the questions from the people who are here tonight. If I run out of those, then we have some other questions from Facebook and Instagram. So early on in the chat tonight, Karen Pomerantz wanted to know if any of you would like to discuss the New York City masking policy, this new idea that you must unmask in a business, or at least show your face at the door before you go in. Does anyone want to address that?
I was watching the news the other day, and I know I have not been asked in those big stores, say for example, Trader Joe's or Whole Food, they don't require, but those smaller bodegas and smaller stores where they are targeted by people, robbers, or vigilantes. So one of the news this week was they require them for safety reasons, not for any health reason. But a lot of people are taking advantage of the mask mandate to do bad things.
I'm not even certain that the problem is that I'm not even certain that the crime statistics are correct. If you look at the crime statistics, and I work in a College of Criminal Justice, so I have those statistics all the time. The mask didn't play a big role. That's just an excuse. That really is an excuse.
Agree.
INTJ would like to know, can you please share what you estimate the situation might look like 1 year from now? For example, roughly what percentage of people might be suffering from long COVID, and what would the implications of that be?
Well, as I mentioned in my talk, the forecast, they are predicting that new cases, if you remember my slides, on a weekly basis, there's about 1,500 new cases, and each one behaves differently. Some people might have very mild long COVID symptoms, some might have moderate, and some have severe. So we really don't know based on the risk factor of people who are affected by COVID. Some might not have any at all, but some might have as bad as Dr. Robi. So it really depends on your condition, your state of health, and risk factors. So I don't know if there are any data out there that is forecasting long COVID effects. So I don't know, maybe Dr. Robi has something to add.
I don't have any data either, because I don't think we can do anything but extrapolate. Yeah. And which I think we can reasonably do, given the fact that in the United States, the number is about 30% of people who had COVID contracted long COVID, and so that's the number that is sort of the agreed upon number around the world. But of course, it's an estimate, and it's going to take years for that to really be sorted out. So I expect that we'll still have that same percentage of people going forward, and we just don't know what the virus is going to do in terms of mutations.
Right. And I think this week there were just 2 conflicting studies that were published on long COVID and Omicron. One that said Omicron is increasing long COVID possibilities, and the other one contradicting that, saying Omicron is less likely to lead to long COVID. So we really don't know.
I saw those as well.
Mm-hmm.
Jenny from Texas wanted to know, it is getting increasingly difficult to advocate for masking among other precautions, especially when medical clinics and hospitals are dropping these precautions. I always mask indoor and outdoor in public because I'm immunocompromised. However, here in Texas, the majority are acting like the pandemic is over. How do we advocate when healthcare institutions and medical providers are dropping precautions?
I think we should not politicize this COVID pandemic.
Yeah. Too late. Yes.
Because we need to believe on science and what is, the science behind. We have this data from the CDC, and a lot of our politicians just ignore the data, and they just say, okay, no more masks in school, no more masks in these areas. But really, it contradicts the science. So protect yourself. It is common sense. You see the data. So, a lot of people think that it is not important, but your life is important, and you need to protect your life because you only live once.
Yeah, and I agree with the non-politicized part. So I was in Mexico City in January, and I was absolutely astounded at the fact that about 90% of the population, indoors and outdoors, were wearing masks. Native Mexicans, not the tourists, unfortunately. But and I asked a friend of mine who lives in Mexico City. I said, how come so many people are wearing masks when we're dropping them left, right, and center in the United States? And she said simply that mask wearing was never politicized in Mexico. And this is why the majority of the population remains in mask and has adopted mask as a normal common measure for protection, not only of themselves, but of their community.
Jenny from Texas would like to know, since Evusheld ended due to not being effective on the most current strain, are there others like it on the horizon?
Trials are actually in place right now for 2 new monoclonal antibodies, yes. But everything has slowed down again because funding has dried up. And you can't have a human trial without funding, right? So we're in that situation right now. And, funding for treatment, for vaccines, but also funding for maintaining case and variant checkup. Those two are tracking cases and tracking variants as well. So we're basically, I like to use that analogy of not only are we lost in the woods, but we've thrown away the map, we've thrown away our backpack with the food, and certainly we've thrown away our flashlights, and so we don't know where we're going right now.
Julie Tudor would like to ask, how might we go about updating universal precautions to include air quality controls, increased ventilation, and air purification? It feels like we were entirely unprepared to handle airborne pathogenic diseases, and our universal precautions need to accommodate all forms of transmission, whether through fomites, droplets, or aerosols.
Well, universal precaution is basically the use of gloves and masking. Again, it requires funding. If you require all institutions to upgrade their air quality, indoor air quality, that's a lot of money. And there's not enough funding for all these facilities. So it's really important that there is ventilation. It's important that we wear masks in anywhere. Say, for example, in a subway, what air quality are we having? No matter what they do in a packed subway car, there is no air quality there. People should just do what is right to wear masks, and it's a common sense. So I think that's a challenge that's up for the government.
I completely agree. Yeah. This is not going to be something that we can do without funding, and certainly not without the political will either of doing that, especially now that we no longer have that pot of money that we can use without all the paperwork of going through Congress.
But I want to add on that, in the hospitals, we are required by the government to, if it's an airborne isolation, we are required to have a negative pressure rooms that we have to comply. But if you have to extend it overall, not a whole lot of these are airborne or airborne diseases, because we don't know how many people have COVID. Some of them don't even know they have COVID because they're asymptomatic. Some people transmitted, they don't want testing. So, it's very hard. It's very hard to implement that from a practical standpoint. I have a question. I have been asked. Oh, I'm sorry, Sarah. Are there still other questions that we need to field?
We have questions, but you can
Okay, go ahead.
definitely pivot into a question. That's fine.
Okay. Should we have annual COVID-19 vaccines?
Depends on the vaccine. Right.
Well,
We still have that. We're still with the mRNA vaccines, which are very ephemeris, to say the least, and that have to be tweaked each time for the variants du jour. I would say that might not even be enough.
well, the thing is, I think there's been a lot of different ideas and thoughts, because unlike the flu vaccine, the flu is a seasonal vaccine, and there's about 107 strains of flu, so you just don't know which strain will be, so they're just predicting that this is a strain. However, with COVID, we don't know much about COVID, and COVID changes, and there's a lot of mutation in different strains, and we have not developed the vaccine for the strain that we don't know. So I think that annual COVID vaccine might not work, because if you give the vaccine, let's say Moderna, you probably have about 97% efficacy. 6 months later, you probably have 78%, and that's what the data shows. Pfizer has about 67%. So you don't know whether you're really protected over time with that with the vaccine. So that's why people question, should we have an annual? Some say no, because we don't know what strain. And other people say, well, instead of having a booster, we should just have an annual, just like the flu. But COVID doesn't behave like a flu. That's why we don't do it annually. That's all.
No, that's absolutely true. And this is again where we are once again hitting the wall of COVID is the flu, which is not. The comparison between COVID and the flu were from the beginning, right? But yeah, if it's an annual vaccine is not gonna be doing great, and there's certainly the current vaccines that are in development right now, which are the pan-coronaviruses vaccine, which doesn't just take care of the different strains of and variants of SARS-CoV-2, but also take care of MERS, which we haven't talked about, but there's still there, by the way, and it's still killing in the Middle East. And my worst nightmare would be the recombination of MERS with SARS-CoV-2, and that would be an absolute nightmare scenario. And SARS, as well as the 4 other strains, which are less pathogenic but still a little problematic. That would be the ideal, but you need funding to get those to move on in their production. I think Novavax is actually a pretty good annual one that we should recommend.
Yeah, because it is it's an arm. It's not an mRNA.
No, it's a protein based. Yeah,
it's a protein based. Yes, I agree, but I think there. I don't know about the funding and approval from the FDA is an issue.
It is, and again, even for approval to the FDA, you need funding to get to that stage as well. So.
All right, so we've got about 2 minutes left. We really wanted to get a masked selfie for our social media. So if anyone would like to go grab their favorite mask real quick, and then turn your cameras on if they're not.
Oh, nice. Hi, everybody.
We really appreciate it. We're really grateful to have our experts here, Dr. Korthels, Dr. Tamargo, Dr. Pesola. Thank you so much for being here. And we are so grateful that this community exists and that all of us are still working together. And I was telling Julie the other day, you know, I think if there's one thing that you can do to save a life, it is to wear a mask, because you have no idea what little chain of transmission you might have stopped just by being extra safe and extra cautious for yourself. So thank you all for being here. I'm going to take a picture in just a second. So 3, 2, 1. Please reach out to us through Facebook, Twitter, Instagram. I got involved just because Julie put out a tweet one day saying they were looking for more people, and now here I am. So if you are interested in volunteering or being part of our organization, please reach out to us. We'd be happy to have you. And thank you so much. Look out for more of these. Sign the petition in the chat. We'll have the recording up in a few days on our social media for anyone who missed it. And thank you all so much. Have a wonderful evening.